Okay, I would like to welcome everyone to the University of Texas MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference for 12/15/2020, and this is the last IDMCC of 2020. That's pretty exciting, isn't it? I think that many of you probably got a second invitation to this conference this coming Friday. That was bogus. That was originally scheduled, but we had to move it to today. So this is it. This is the last one. Okay, and I'll talk about the January conferences at the very end. Let us see. Let's moving forward. Okay, we got to rock and roll because, as you know, because this is a work day, we have a rigorous stop time of 7 a.m. Hopefully a few minutes before to allow everyone to get to their 7 a.m. conferences and that type thing. I would encourage everyone, when you want to speak, to unmute and then remute, okay? I have designated several co-hosts which will be monitoring the participants to silence any inadvertent open mics, but I want to encourage you to speak up, okay? We love to have interaction. All right, let's start with the MRI warm-up, okay? And here it is. Now, the first thing I want to say is the lesion is not present in this image, this particular image. It's not here, okay? What is your diagnosis? And then I'm going to ask you to justify it. Anybody want to unmute and give me a diagnosis? Now, remember, listen, there may be a few people who have not attended the conference before. That's going to be pretty rare because this is mainly the hardcore group that gets up early on a Tuesday for a 6 a.m. conference. When I say what's your diagnosis, what I mean is what's the differential diagnosis, but all I want to hear is the number one entity at the top of your differential. And as we know, the differential diagnosis is not a random list of all 120 plus brain tumors. It is what is statistically most likely based on the data that you have, statistically most likely. And the differential diagnosis changes as I give you additional data, and we'll see how that plays out for this particular case. But right now, I have given you everything you need to actually give me a diagnosis which only based on what you have here is at the top of your differential. Now, this is paradoxical, isn't it? Because I've told you that the lesion is not even it's not in this cut. So how could you possibly formulate a differential diagnosis? And yet the data are there, all right, to tell you, but you're going to have to think outside the box. You know, we need in this conference, we go beyond matching pictures with the book. So there's a typical intern in pathology, looks through the microscope, sees a feature, constellation of features, and then goes to, in the old days, you went to the book. Okay, today you'd go to the web, you'd go to your iPhone, you'd go to your smartphone, and you'd match the pictures, all right? Ultimately, if you want to achieve a higher level of performance, a higher level of intelligence, you're going to have to think outside the box. Use non-conventional approaches. Use non-conventional data. All right? And I'm talking about solving the most difficult challenges that will come your way, not the easy stuff. That's not really what we deal with here. I mean, we will to a certain extent. In fact, we're going to end with bread and butter, the conference later today. But now we're thinking outside the box. Okay, I tried to get the chat function going and I moved it over the other screen, but now it's disappeared. So I'm going to need someone to unmute, speak up, and tell me what is your differential, what's your diagnosis, and why. There's actually a reason based on the image I've showed you. Now, this image, by the way, you know, current cases, correct? Yeah, always current cases. And this image is reproduced exactly as it was in the electronic medical record. That's a clue. Anyone? No one?
Since it's this is Octavio. Since it's a sagittal.
Wait. You're describing. I don't want a description. I asked for listen, precision.
Okay, let's say pituitary. Let's say pituitary adenoma or something.
Yes, thank you. Now, see, that's all I want. That's much more powerful than describing, right? It's just pituitary adenoma. See, what I want. This is Octavio, right? Octavio, I wanted you to stun everyone by saying pituitary adenoma, and see. But you started out with, well, this is a Do you see how powerful it is just to say pituitary adenoma? Now, Octavio, everyone is wondering, how did you know pituitary adenoma? Can you explain? Very simply, concisely. What was the key?
because it says sagittal post-contrast fat SAT MR, and there are some questionable post-surgical changes in the paradisal sinuses?
Stop, Octavio, stop. Remute yourself. Good, you got it. No, here's the reason. The reason is it standard of care? Let me ask you a question. I told you this image is reproduced exactly as the EMR. Is that correct? Is it the standard of care at MD Anderson Cancer Center, Department of Neuroradiology, to cut off the top of the cerebrum and everything from about the 2/3 of the cerebellum to posteriorly, because there's no pathology that ever occurs in the occipital lobes? Does that make any sense at all?
No, for sure not.
Yeah, yes. Look, that was the clue. The clue was you're not seeing the whole brain. Now, this is on purpose. This was a pituitary series. It could have been an IAC series, internal acoustic native series. In other words, the image is coned down to the region of interest, and the region of interest is the epicenter, the center of the field, and that's to be more precise, because in this particular case, that's where the action was, and it was ordered as pituitary series. Listen, at our what was it? It was I think it was the Monday afternoon neurosurgery conference. I believe it maybe Dr. Schomer said about a particular, I think it was lumbar tumor, lumbar cistern tumor, something like that. He said, listen, if you want the most precise imaging, don't order a spine series, order lumbar. Just lumbar, it will cone down and you'll get much higher quality. Okay, did everyone love that? Now look, this is what I'm talking about, thinking outside of the box, right? And I've actually, for those who've been attending the conference for a few years, I've done this before. It's not the first time, but it goes way back, way pre-COVID to when we were in the multi-headed microscope room. So everyone understand, the key here was, since I told you it's not in here and there are no clues at all in here, the clue was, it's a pituitary series. How did you know that? Or an IAC series? I would expect a vestibular schwannoma. Sure, anything like that, anything you wanted to give me. But listen, statistically speaking, when you have a specified study, MRI study, ordered to look at this area of the mid-skull base, pituitary adenoma, maybe microadenoma, is going to be the most likely thing, and that's why I was looking for pituitary adenoma. So again, Octavio, I'm giving you an A+ for pituitary adenoma, but here's the thing, I wanted everyone to know, Octavio probably looked at this and didn't even think, oh, it's pituitary series, but see, we have a lot of pathologists attending this conference which wouldn't recognize that. You like that? Okay, do you think that's not fair? Maybe it wasn't fair, because you could have thought that I trimmed this image on purpose. That's why I said I reproduced this image exactly as it was. Did anyone hear that? Did you pay attention to it, or did you think it was me blathering away? That was a clue, and if you ignored it, maybe you won't in the future. But here's the point. If you ignored that, how much are you ignoring in the tissue or in the images that the tissue section, the image is trying to tell you, and you're not listening, just like you didn't listen when I said this image is reproduced exactly, and you didn't have to happen to think, well, I wonder if MD Anderson has such sloppy imaging all the time. You got it? Okay, that's sarcasm. Okay, yeah, pituitary adenoma is number 1 on your differential for the reason we said. Okay, why? Because it's a pituitary series, and you know, because the top of the brain's cut off, the posterior brain's cut off, we're looking at the center. Okay, now, this is the same case. That was a far parasagittal cut. I thought it would be an interesting lesson just to see how familiar with the imaging, yada, yada. Okay, here it is, 27-year-old male. All right, there's the background. All right, what's your diagnosis? I want a diagnosis. I'm very happy. Anyone wants to unmute and say pituitary adenoma, please feel free.
Tuberculum meningioma.
I'm sorry?
Tuberculum meningioma.
Hey, listen, tuberculum meningioma would be perfect if, see the big supracellular component? If it were going forward in the direction of the tuberculum, it would be a tuberculum. It's flipped. So it's going the wrong direction for tuberculum. See, the tuberculum is the most posterior of the planum sphenoidale series, correct? It should be going anterior, that suprasellar. In fact, I almost put in a tuberculum, and I just didn't have enough time because I was going to put in a standard pituitary adenoma, a tuberculum with the anterior going rostral component, and this thing, which is going south. It's heading posterior. But listen, I like the fact that you did not say pituitary macroadenoma. Okay, so here's second opportunity. What is your diagnosis? Clearly, it's not pituitary adenoma. What's your diagnosis? You have all of the information you need to make an intelligent. It's not pathognomonic, right? But you have all the information you need. Now, needless to say, I'm sure Octavio's not speaking up, and Kristen Huntington probably not, because this was presented at Tumor Board, and so clearly, and I think I don't have to say this to this group. If you have prior knowledge of a case, it's not a sign of intelligence to speak, give an answer and you actually cheated. Cheating is really not a sign of intelligence. But see, I know that our inside people know that they're not going to do that. Okay, someone who is unfamiliar with the case, give me a diagnosis and justify it. Anybody? Okay, did I say 27-year-old male? Did you ignore that? Did you ignore the fact that this?
Germinoma.
Yes, thank you. Germinoma. Germinoma, why? Number one, this imaging is not characteristic of pituitary macroadenoma. Could it be a pituitary macroadenoma? Yes, absolutely it could. There's always a spectrum. And if there's a spectrum, a Gaussian or normal distribution of basically every feature of every tumor, the imaging features at the two extremes of this normal distribution, yes, this could be pituitary macroadenoma, but that's not going to, but that's not going to be at the top of your list because this is an unusual morphology. It doesn't mean it's not pituitary macroadenoma. It's a red flag saying before you jump mindlessly into pituitary macroadenoma, which is the most common, I can understand that. This is a red flag saying think. Could it be something else? And one of the first things you would think of, well, pituitary macroadenoma, pituitary adenomas in general more common in women. So this is a woman. Oh, wait a minute. No, it's not a woman. No, this is a male. Oh, okay. Well, pituitary macroadenomas, it's like, okay, male. So you go to male, and so this is a 65-year-old man. No, wait a minute. This is a 27-year. What would a 27-year-old male be doing with a pituitary macroadenoma? Yeah, of course it occurs. Look, everything occurs. We're talking about what's statistically most likely, and all of a sudden it might occur to you, you know what, 27-year-old male with a brain lesion anywhere, you have to have germinoma in your differential. 27-year-old, 20-year-old male, germinoma better be there. What's the third most common location of CNS germinoma in these young males? Yes, basal ganglia, the basal ganglia. Now, if you didn't know that, that's just a failure of your knowledge base, which is okay. You can build factoids. All right. If you didn't know that basal ganglia / thalamus is the third most common location after the pineal and the suprasellar region. Those are number 1 and number 2. Basal ganglia number 3. But now you know. Let's just pursue that just for a second. What is one of the more interesting imaging presentations of basal ganglia germinoma in a young male? Imaging presentation. Anybody know? It's counterintuitive. The answer is shrinkage of the basal ganglia. Smaller, not bigger, with the germinoma. Did you know that? We've talked about it again once or twice in the conference before, but I'm not sure if anyone listening to this conference was here back in the day. We'll cover it again. Okay, are you enjoying this? We having fun? Okay, you want to see the histology. Here's the histology. All right, everyone good for it actually is a pituitary adenoma, right? Yes or no?
No.
No, why?
Adenohypophyseal tissue.
Correct. Right on. Notice the normal acinar organization, little balls, right? And notice the different cell types in each one. This is normal adenohypophyseal tissue. Thank you. Would you like to see another area of, and all this, listen, the reason why, you know what, why I put this in? I put it in just to show you, because in the surgical specimen, the tumor is truly involving the pituitary in the cella, not just supracellular. That's one of the points. Ready for the next image? Here it is. What's your diagnosis?
Germinoma?
Okay. Thank you. Yes, good job, germinoma. Hey, listen. One of the things I'd like for everyone to do between now and the next conference is work on unmuting. You know, your unmute skills. Find that button, and so fast. Yes, good job, germinoma. Look, it's a biphasic cell population. You have these giant epithelioid cells. That's one population, and then you have these tiny little reactive lymphocytes. That's biphasic or bimodal distribution, which is, this is, germinoma is the hallmark tumor for bimodal cell size distribution. Large germinoma cells, small reactive lymphocytes. Okay, I will show you the diagnostic immunostain next. What's it going to be? What immunostain am I about to show you, which confirms germinoma, even if we didn't have it? Yes, exactly. There we go. Again, look at the germinoma cells. Nuclear stain, because it's a transcription factor. Lymphocytes are negative, OCT3-4. Sometimes it's called OCT3, OCT4, OCT3-4. Absolutely, very robust stain. What was the stain we used in the old days? Before OCT3-4, what was our go-to marker? PLAP, very good. Placental alkaline phosphatase. I almost photographed it for this conference. It turns out it was magnificent. Frequently, it's stone cold negative. So back in the day when PLAP was our best immuno and it was stone cold negative, what was our diagnosis? Germinoma, because everything else fit, the best we have. But now we have these more modern markers, which are fantastic. C-kit, exquisitely sensitive, very robust, not specific, but wonderful. Okay, so this was, bottom line, this was a supracellular germinoma in a 27-year-old male. Everything fits perfectly. What was the key? Listen, what was the key to the whole case? The pre-op imaging looked funny. It looked peculiar. Now, it doesn't mean that it wasn't pituitary macroadenoma. That's still going to be the most common tumor in this location, but this imaging is telling you, wait just a minute. It's a red flag. Red flags mean slow down. Slow down, take your time, make sure. Red flags raise the bar in order to make a diagnosis of the most likely, most common, the prosaic diagnosis. They raise the bar. It says bring in all 8 Venn diagram spheres of information, convergent data. Don't leave anything out. Make sure everything fits. You like that case? That was good. See, this is the sort of thing that I want to talk about in the conference, not just and the next entity is, and the next entity is, and let's look at the 10 different, tumor types of the yada, 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 which is what you see in fellow and resident conferences every single day of the week. And you know what a lot of them are? It's let's read the book together. All right, let's get together and let's read the book. Because that's what you do if you don't have experience. Now, once you have experience, then you can try to help the young people with the traps, the pitfalls, the things that might hurt patients. And that's what we like to do. And we stress principles in the conference, not just factoids. Okay, you like that? Okay, MRI challenge. Now listen, I'm calling this a challenge rather than an IPR or a warm-up, because you're going to have to use maybe 3 neurons. Not just the 2 neurons that you're used to activating in diagnostic, radiology and surgical pathology. You're going to have to engage 3 neurons. I want a specific, precise diagnosis. Everyone ready? It's a good one. I like it. Ready? Here we go. Diagnosis. Be thorough. Be complete.
Hemorrhagic melanoma met.
I like that. Hemorrhagic melanoma met. Statistically, most likely. What you're seeing is a fluid level, also called a hematocrit level or blood fluid level. And the reason why it is vertical is because imaging is done, not always, but imaging is done. Remember, the patient's laying flat on the bed of the scanner. Quick question. What if I were to tell you that this, I messed that up totally. what if I were to show you the same image, only it were a horizontal blood fluid interface, horizontal? It could still be the same answer, and what you would say was, it appears that the patient was imaged in an upright scanner, a sitting. You know, there are scanners, MRIs, you just sit, you sit on a chair, that sort of thing, right? Typically, they don't have the magnetic strength that we use, less resolution, yada, yada, yada. Anyway, bottom line is fluid level, hemorrhagic melanoma metastasis. All right, that is great. I love that. It's statistically very good. That's not what it is. So go again. It's not metastatic melanoma.
Ruptured mitotic aneurysm.
Ruptured, no, okay, that's good. I like that. Ruptured aneurysm, I like that. Okay, no, it is a neoplasm. It is a tumor. It's not metastatic melanoma. Go again. Anyone? Go again. Keep going. Hey, did I say that there's always a differential? And if all you get, if all you've got is metastatic melanoma, and then it's like blank, it's like I got nothing. What are you going to do when you run into a case like this when it's not metastatic melanoma? Man, you're putting all your eggs in one basket there, aren't you? It's like my differential diagnosis is one entity. That's because you're so good you always get it right from your first gestalt. I guarantee you 10% of your diagnoses are absolutely wrong. Give me another one. Remember I said neurons. Have you seen anything that looks like this before that's not hemorrhagic? Ooh, that's a clue, isn't it? What is it? What's the diagnosis? Ever seen this with no hemorrhage?
Cystic GBM.
Yes, thank you very much. You like this? This is susceptibility, SWI. Isn't that beautiful? Yeah, look at that blooming artifact, the blood component. Yes, this is just a glioblastoma, IDH wild type, cystic variant with hemorrhagic presentation. Anyone ever see this before? Yeah, I've shown it about 10 times in the conference. These are 10 different MD Anderson Cancer Center patients with cystic glioblastoma. All right. The differential diagnosis for all of these would be metastasis. Absolutely. You could put in pyogenic abscess, even though it's a little irregular. Definitely. There are always exceptions. You want to see the diffusion weighted and ADC map, T2 trace going along with that. But these are all cystic glioblastoma. Did it ever occur, did you ever think, like when I was showing the scam or when you're looking at one of your own examples of a cystic glioblastoma, you know, what are the unique features of cystic glioblastoma? Well, number one giant cyst, a single cyst, not solid mass with little multiple internal cysts. Number two, very little, listen, very little vasogenic edema, very little. That's because the infiltrating edge of the glioma around the cyst tends to be millimeters, tiny, as opposed to diffuse, you know, all the way up into the cortical ribbon, et cetera, et cetera. So that's one of the unique features of cystic glioblastoma that can mimic circumscribed tumors like JPPXA ganglioglioma, right? And so these are all the pitfalls we talked about before. Listen, did it ever occur to you that, you know, glioblastomas are probably the most common primary brain tumor to present with hemorrhage, but usually the imaging looks like a glioblastoma with focal hemorrhage or multifocal hemorrhage. It's relatively rare, listen, it's relatively rare for a glioblastoma to present with an imaging picture that the radiologist would say lobar hemorrhage, lobar hemorrhage. Quick question, which primary brain tumor not infrequently, I'll use the double negative, not infrequently presents with a lobar hemorrhage picture? Which primary brain tumor? Which one?
Oligo?
Yes, oligodendroglioma. Good job. Okay, but back to this. Did it ever occur to you, listen up. Every cystic tumor you can think, ever heard of cystic meningioma? Yeah, one giant microcyst. Yeah, cystic schwannoma. Yeah, all of them. All of them have a hemorrhagic variant. So they hemorrhage. And where does the blood go? Blood goes into the cavity, fills up. Did it ever occur to you that this could become this? Look at that. Here's the T1 post of our present case. Just eliminate that fluid level. Look how it fits into the spectrum. It is exactly like all the others, except it bled. Do you like that? I'm going to tell you something. Honestly, I'm sure these have come through MD Anderson before. This is the first one I've ever seen myself personally, which doesn't mean anything. It's just I thought it was super cool and I thought I would bring it to you. Now, listen, here's the key for this. The answer to the original question, what's your diagnosis? And the answer was metastatic hemorrhagic melanoma is the correct answer, because statistically that's most likely, but there's always a differential. That was the key. So all I wanted to see, listen, all I wanted to see is that everyone thought of, you at least thought of, I wonder if it could be further down on my list, way down on my list, cystic glioblastoma with hemorrhagic presentation. Or how about pleomorphic xanthoastrocytoma with hemorrhagic presentation? Or how about cystic ganglioglioma with hemorrhagic presentation? Astroblastoma, circumscribed right hand with hemorrhagic presentation. Everyone got it? See, it's just that flavor. Don't let the hemorrhage throw you off or lead you down the garden path to, oh, this case does not have a differential. Everyone got it? Yeah, principles. Okay, here we go. Language Watch. I started doing this, well, a few months ago, and turns out it's a popular feature. So let's go again. Okay, we're going to do one of these say what. Say what? It's like what? Now look, this is what this relates to. We talked about it before. Listen, here's what I get from many, and I've gotten in the past from many of my colleagues, not just talking about MD Anderson, I'm talking about my specialty of oncologic neuropathology, and it goes something like this. I am not a neuroradiologist. I'll look at the scan cursorily, whatever, but what I really want, I want the radiologist to tell me what the diagnosis is or what the differential is. That's what I want. I don't even want to read the report, etc. Now, the problem where that breaks down, that is perfect for inside cases at MD Anderson Cancer Center, because that's what I want too. I want one of our expert oncologic diagnostic neuroradiologists to tell me the full differential and all that. Yes, that is what I want. Here's the problem. Over half of my cases, over half of my patients do not have an MD Anderson expert oncologic neuroradiologist interpretation. There's too many of them coming in from the outside through the clinic. We would have to triple the number of neuroradiologists on faculty, and the institution's not going to do that. I would love it if we could have that. And there's a mechanism for requesting interpretation, but you can't abuse it, you can't overuse it. So here's the bottom line. In the majority of cases from the outside that I am responsible for diagnosing, to confirm the outside diagnosis, or in about 8% of cases to refute the diagnosis, it is up to me to read the images. Now, there is for sure, is or was, an outside imaging report. Sometimes it's easy to find in the record. Most of the time it is not. It's either not there or it's buried in a 200-page PDF in the medical record, unorganized, and you got to scan through it. And yes, I have done that. I've done that to find an outside surgical op note which might have a critical piece of information I need. All right, but listen, let's go back to the premise. The premise is, I'm not a neuroradiologist. I'm not a radiologist. All I have to do is read the report, listen to the radiologist. Here we go. Referring institution report. Focal ovoid, soft tissue mass, right frontal lobe, yada, yada, yada. Look at the underline. There are no areas of abnormal contrast enhancement, including the tumor within the superior frontal cortex. Here's this would, in Anderson, this would say impression. On the outside, this particular practice, it was conclusions. Marked, yada, yada, yada. Marked increased signal on the T2 weighted images. No apparent contrast enhancement. In fact, I've looked at the images. There is no enhancement. Everyone got it? Ready for the bottom line? Glioblastoma is suspected. That should give you pause. Are you happy now just reading the reports? There's nothing distorted here. This is it. Now listen, you know what I do? I see the same thing. One of the advantages that I have, I think, or that we have here, is we do have a fair number of these outside reports. And I read them all the time. And I can tell you that it's just like we see in every other area. In neurosurgery, there are neurosurgeons who do primarily maybe spine work, see a brain tumor maybe 2-3 times a year maybe, that operate in ways that amaze our neurosurgeons here at MDA. It comes up all the time. Kristen Huntoon can attest to it. It comes up at our tumor board in the Monday Neurosurgery Conference. Why did they do it that way? It's the same way with pathology. 8%, roughly, give or take, community diagnoses in the challenging cases are wrong. All right, serious diagnostic discrepancy. Listen, it is the same thing with the referring institution radiology reports. It's no exception. Now, you know what I do? Listen, you know what I do when I see a path report from the outside that says diffuse astrocytoma, WHO grade 2 of 4, grade 2 of 4. Okay, that's fine. Here we go. How about this? Oligodendroglioma, grade 2 of 4. Grade 2 of 4. And I'm thinking, now, wait a minute, oligo grade 2 of 4, that's going way back to the day when anaplastic oligo was presumed to give rise to glioblastoma, just like astro could do, just like ependymoma could do. And you know what I do when I get those cases like that? It's clearly a throwback. I always look the pathologist up. You know, you go to the net, everything's out there, look them up, and inevitably, you know, they're going to be 70 years old, no CME, that sort of thing. Sometimes 60s. Now, I'm not saying you can't make diagnoses because, you know, I'm going to be that age. and I hope I follow the Norman Leeds pathway. Dr. Leeds, the legend, who we lost tragically at what I would say is far too young of age, of over 90, was still practicing at over 90 years of age and contributing to all of our conferences. Okay, so I'm not saying that, you understand. Here's the problem. There are pathologists and radiologists that are not doing their CME. Let's put it that way behind the time. All right, you don't want to count on that. Okay, point made. Everyone like that? Okay. Let's move on. MRI and H&E warm-up. I've never done this before. This is brand new. MRI and H&E warm-up. Oh, it's going to be both. But wait, there's more. I think I want to take it a step up from the hemorrhagic cystic glioblastoma. I'm going to make this a professorial challenge. All right, that means this case, and it's going to be at both levels. That's the cool thing. On the imaging and on the histology, this case is really most suited for a full professor that's been in practice for quite some time. You want to try your hand? Yeah, of course you do. Let's try. All right, 4-year-old female. Here we go. Diagnosis. Feel free to unmute anyone who wants to and give me a diagnosis. Now, you know, if we were back in the 16-headed microscope room, I would be, the first thing after you make a diagnosis, I would always say, you know, if you get it right, I would say, is that a lucky guess? What is your justification? Evidence-based medicine, facts, evidence-based medicine. All right, so, but just anyone have a diagnosis? And of course, you know, it's not pathognomonic, right? Said that before. What I'm looking for is give me a very plausible diagnosis, right? And then based on what? What's your evidence? Now, in order to do that, you're going to have to sort out what is going on in this image. You're going to have to recognize neuroanatomy. It's actually gross anatomy in this particular part, in this particular case. Put it together, put everything together, and give me a plausible diagnosis. And there's a good way to do that. Would anyone care to unmute and venture a guess? Otherwise, I'm going to go to the next slide.
Recurrent.
Okay.
Ependymoma.
What's
maybe?
that?
This is
I'm sorry, say it
Octavio.
again?
It is a recurrent ependymoma.
Thank you. Right on. That's Octavio, right? Okay.
Yes.
I have to tell everyone, Octavio Arevalo is our current Oncologic Neuroradiology Fellow. That's why he is so good at all of this. And I think Octavio has not seen the case. He's not familiar with the case. Octavio, very succinctly, tell us why that you're saying that this is ependymoma.
First, because of the patient's age. Second, because the patient had a right retrosigmoid craniotomy. Third, because the mass is occupying the perimedullary system, but is extending through the Loschka foramen into the fourth ventricle. And
That's it. That's perfect. Stop. You don't have to say any more. All right. Did everyone hear what Octavio said? It was perfect. It was magnificent. Number one, he used the patient's age, 4 years old. Ependymoma is going to be one of the most common tumors, posterior fossa, along with pilocytic, which this does not in any way look like pilocytic, and medulo. It could be medulo. I would give you that, but it is best for ependymoma. Octavio also noticed that there had been this retrosigmoid craniotomy, so that's why he put in recurrent. Magnificent job. Here's the thing. the key I was looking for was lateral recess. It's growing through the lateral recess, in the lateral recess, through the right lateral foramina of Luschka to fill up the prepontine cistern surrounding the basilar artery. That's called plastic ependymoma back in the old days. That's what they do. The key, okay, well, hang on a second. I said this was a challenge both ways, right? So I really like ependymoma as top of your list for all the reasons that Octavio said. However, this is the histology. Here is the histology. Now we have the professorial challenge, same case, to my current oncologic neuropathology fellows and former neuropathology fellows and other neuropathologists who may be listening. What is your diagnosis? All right, just think about it. Let's go back to the imaging, deal with that first. The key here was recognizing the neuroanatomy. That's the medulla. All right, informal, if you're at a party, medulla oblongata. Quick question. Medulla oblongata, that's the formal name, right? Back in the days in Latin. Medulla oblongata, you know, have you ever heard like you shouldn't use part A if there's no B? Like if there's an A, there's always a B. If there's a medulla oblongata, maybe oblongata distinguished what we just call medulla today from another medulla. What is the other medulla? Gross anatomy, gross neuroanatomy. What is the other medulla? What was the name?
Spinal cord.
Spinal cord.
Yes, medulla spinalis, the spinal cord. Good job. That's why oblongata. All right, the medulla. The key here was recognizing the medulla. Now, once you have the medulla oblongata, then, you know the cerebellum, then you see lateral recess because you know the neuroanatomy. You think, okay, tumor in the lateral recess, come on. Now, excuse me, now, of course, put choroid plexus papilloma, yes. Atypical teratoid rhabdoid tumor of the lateral recess, yes, absolutely. All of those are in the differential diagnosis. But again, when I say diagnosis, I just wanted statistically what is most common of all of those, and it's going to be ependymoma doing this behavior, right? Okay, and then here we go. There's a lateral recess, prepontine cistern, and that's how we put it all together. Now, this is why it was a professorial challenge. Now, as it turns out, Octavio, well, he's a step away from becoming faculty, right? I mean, by the time you reach a fellow level, you're not quite full professor, Octavio, so don't let this go to your head, okay? I'll design one more challenging next time. Okay, here we go. Let's look at the neuroanatomy. Every pathologist that's going to brain cutting, you're performing brain cutting, it's worth spending a little time on the skull base, this region, to look at the neuroanatomy. It is magnificent. All right, this is the cerebellopontine angle anatomy. Here it is up close. What I've circled are the two lateral foramina of Luschka with a little tuft, see the granular tuft, of choroid plexus protruding through. It's right there. What does that mean? It means that there is such a thing as primary choroid plexus papilloma of the cerebellopontine angle. It starts right here at the choroid plexus tuft that's right at the foramen, and it grows in the path of least resistance, which is into this large, capacious CPA cistern. And so it presents as a CPA mass in its primary choroid plexus papilloma. All right, let's go to this is a Fuller and Ballister, Histology of Pathologist 5E, and look at the letter F's. All right, labeling exactly the same thing in a different specimen. Histology for Pathologist 2020. All right, I guess I have to give full disclosure. I didn't get a dime for writing any of the editions of this book. It was a labor of love and continues to be. All right, so here it is. And imagine, all right, see the yellow line? Imagine let's take a cross section, an axial section right through the lateral recess and foramen of Luschka. Here it is. And we're just doing this on the right side. So you can see the medulla central, the cerebellum lateral, and then here comes the lateral recess, all right, wrapping around the medulla, and filling the recess is this choroid plexus coming from the roof, right, bilateral rows in the roof of the fourth ventricle, then each of the two tufts turn laterally and head through the lateral recess out of Luschka, all right, and then the next, all right, this plane that I've shown in yellow, that is the lateral foramen. Can you see the two sheaths of ependymma-lined glial tissue, all right, on lateral and medial? Those frame the lateral recess, and you're seeing the end. The end of them is where the yellow line is, and that ependymma transitions to pia as we turn the corner and head back up and around, and then over the medulla and over the cerebellum. So that's the foramen. Now, in this particular case, the tuft is protruding through the foramen, which is the case in embryos, neonates, et cetera, tends to retract back within the lateral recess in adults. So that's the lateral foramen of Luschka. There's actually a name for this lateral recess with the choroid plexus, with this blooming flower at the end. It's the flower basket of Bochdalek, also known as the cornucopia. All right, and here it is indicated by the arrowheads in histology for pathologists, and here's the figure legend histology for pathologists, referred to in the older literature as the flower basket of Bochdalek or cornucopia. Now, I know every neuropathologist and trainee has read histology for pathologists. Could you have said flower basket of Bochdalek? Some could have. It's there. It's been there for 5 editions. You've had plenty of time. I think the point here, you can read a book a million times. You're never going to remember the information when push comes to shove, unless you've had a case and come face to face with it. All right, you like that? Okay, here we go. Yeah, we got to keep moving. And there it is, and all its magnificent. And that takes us back to the neuroanatomy. So it's the neuroanatomy directly relevant. Okay, and here we go. Someone has their cell phone on and they're showing. Let's see, who is that? Who is showing their face? And okay, now it's gone. Very good. All right, ependymoma. That was the diagnosis. All right, who wants to give me a diagnosis? That was the radiologic diagnosis, ependymoma. You got it?
Yeah.
What is the diagnosis histologic?
Signet ring cell ependymoma.
Yes, that is exactly correct. Beautiful diagnosis. Was that Andrea Gilbert?
That was, yeah.
Yes, Dr. Gilbert, Andrea Gilbert, oncologic neuropathologist, UT San Antonio. This is signet ring cell ependymoma. Kudos, Andrea. H&E Professional Challenge. Look at these cells. I've highlighted the ones where you see the signet ring. See the indented nucleus? It's easiest to see in these examples. Signet ring cells. All right, here we go. Lipomatous, extensively vacuolated ependymoma with signet ring cell-like appearance, case, et cetera, case reports in pathology. And then they summarize. Don't you just love these horizontal tables that they put in books? I mean, in papers, the chapters. I just love it. And I thought I would reproduce it just like that. Oh, that's magnificent. Anyway, 27 cases. All right, is it rare? Yeah, it's rare. I mean, relatively rare. And listen, anytime you do a lit search or whatever, and you see something like you find 20 cases or 30 cases, that's the tip of the iceberg. I'm sure you realize that. If there's 30 cases in the literature, there have been at least 300, at least an order of magnitude, that have been seen by pathologists, and they simply did not feel the need to publish every thought they had. Right? Yeah, okay. Signet ring cell ependymoma. Look at this little PubMed search. Signet ring cell, signet ring ependymoma, signet ring ependymoma. It goes on and on and on. The point being, if you thought, wait a minute, I've never seen that, I've never heard of it, you see this all the time. Listen, you see this all the time in conferences. You'll hear a pathologist or a radiologist say, I've never seen. What hubris? Talk about hubris. Man, heading for a fall. Just because you've never seen it doesn't mean that other people haven't or that it doesn't exist. And yet you'll hear that statement made. All right. What is the vacuum do? It's lipid. It's lipomatous metaplasia or heterologous differentiation. Lipomatous metaplasia. Let's search lipomatous ependymoma. All right. I would have accepted lipomatous ependymoma. Or how about signet ring cell lipomatous ependymoma? Look at all the papers in which lipomatous ependymoma is part of the title. Okay, and there's just one example, Brain Tumor Pathology 2016. Okay, this is a little side. Look at this. This is the figure of this paper. Here's the figure. Okay, and I'm going to ask you. This is a brief digression. What's the sequence? What sequence is this? Anyone recognize the sequence? Anyone want to take a crack at it before Octavio speaks up? Do you remember the principles that we've taught before? All of our fellows get a lesson in basic T1 versus T2, T2 flare, all of that stuff. Anyone know how to apply the principles to this particular case? Octavio, what's the sequence?
I would say it's a flare, T2 flare.
Thank you, and thank you for saying T2 flare as opposed to just flare. If you say flare, it's assumed to be a T2 flare. Is there a T1 flare? Of course there's a T1 flare, tends to be sharper, etc. So T2 flare like that. Yeah, it's a T2 flare. Let's look at the caption. Figure 1, axial MRI shows intraventricular mass, T1 weighted image, panel A. See, this is panel A. Well, they're calling it a T1. So I guess you're wrong, Octavio. This is published. I'm sorry you got that one wrong. Oh, and look at the imaging findings. Hyperintense on T1. There it is again. Figure 1A. They're doubling down. And okay, here's the bottom line. Letter to the editor. Hey, look at this list of lipomatous ependymoma. This caught my eye. A letter to the editor. Ooh, this is getting serious. Oh, it's regarding the paper we're looking at. Wow. Oh, and here's the whole letter to the editor. Herein we demand a correction. Man, that's pretty strong. How many of you have participated in writing a letter to the editor? How many of you use the language, I demand a correction? I love that. I demand herein a correction. Bottom line is, it's not a T1. It's exactly what Octavio said. It's a T2 flare. All right? Now look, if you looked at this image when I asked you what's the sequence, if you looked at the side where the tumor is, and you looked at all that hyperintense white matter, and you said, oh, well, it's a T1 because the white matter is hyperintense to the overlying cortical ribbon, then you violated the first rule, Fuller's first rule, probably everyone's, of T1 versus T2, which is get the heck away from the lesion. That's not where you determine sequence. You go to the other side. All right, let's come down on it. Look, right there. See the cortical ribbon? See the white matter beneath it right there? The cortical ribbon is hyperintense to the underlying white matter. It's clearly a T2. The CSF is dark, hypointense. It's a T2 flare. So the authors of the paper missed it. Who else missed it? The reviewers. Wow, what a great job of reviewing. I can't say too much because I've already de-anonymized it. Anyway, I think I better move on. Yeah, it's a T2 flare. All right, now we're still with the same, listen, we're still with the same case. All right, 646, we have plenty of time. Let's move. This is so cool. This is so cool. Signet ring cell ependymoma. Cool. Lipomatous ependymoma. Cool. That's 18th century oncologic neuropathology. Still existing in the 20th century. We need to move on. We need to retain that. Yes, we retain it. So we don't get misled and think this is some signet ring metastatic adenocarcinoma. That's why we have to know it. Absolutely. But let's move from the 20th century to the 21st century oncologic neuropathology. Specifically, look, come on, it's December. January's around the corner. Let's start talking 2021. You know, the WHO is not going to be 2020. How long have I been saying that? Best laid plans, COVID. All right, it's going to be WHO 2021. It'll be coming soon, hopefully first quarter, coming up. Patience, please. Okay, 2021. What's the next slide and last slide of this case that I'm going to show you? What is it going to be? What is the image I'm about to show you? I want to wait for a second, have a little more coffee so I don't slow down, and wait for someone to unmute and tell me, for this particular case of lipomatous signet ring cell ependymoma, all right,
The molecular findings.
Say again?
The molecular findings,
I'm sorry, Dr. Gilbert, you may have misunderstood me. I said, what is the image? Oh, and you thought I was going to show you a table, or no, it's not going to be text. It's not text. This is an image. What is the image I'm going to show you?
The H3K27 trimethylation marker.
Yes, thank you. Okay, I'm going to have to give you an A-, Dr. Gilbert, because you took a while because you took images being text. Okay, is that fair enough?
Wait, no espresso?
No espresso? Are you kidding? You're getting MD Anderson Hospital cafeteria coffee. It's like, what is it, 20 cents now? That's what you get. Here it is. Dr. Gilbert is correct. There it is. H3K27ME3. That's a trimethylation mark. This is posterior fossa. Therefore, the diagnosis in this case is not signet ring cell or lipomatous ependymoma. It's posterior fossa ependymoma group PFA. That is 2021 oncologic neuropathology. It's a simple immunostain. You like it? Yes, of course. The answer is yes. Here it is, anonymized. This is the actual report. Poster positive in group PFA, C impact nomenclature. Until the 5th edition comes out, I'm also putting in the traditional anaplastic ependymoma grade 3, H3K27 protein status, loss of ME3, comment, patient has a history of posterior positive. If there's this, let's look at a typical a good format for comments in 2021, molecular neuropathology. If there's a relevant history, I'll put that up front. Then H&E, oftentimes this is the first paragraph, what it shows, the 2020 shows all of this stuff, all right? And then here, all right, and so here it is, all right? And right there, this is the areas that showed the signet ring cells. Can you see them at the lower power? Okay, are you mad at me that I didn't show you this right off the bat? What kind of a challenge would it have been if I just showed you the perivascular pseudorosettes? It's game up, because that's not what's interesting. This is what's cool about it histologically. And look, here's the transition. Isn't that neat? Now look, here's the point. What would 99.9% of pathologists do? Look, when they see this, they would hone down in on the perivascular pseudorosettes, sign out the case as just ependymoma, and move on, and wouldn't even look at these areas. Oh, it's microcyst, it's artifact. Sloppy, not excellent. Average, average. And if you're satisfied with average, with status quo, well, you are not yet worthy to be a first-tier oncologic neuropathologist, I can tell you that. You like it? Okay, and there it is, all about the group PFA, et cetera, and they're not graded according to the C impact and the forthcoming 5th. Once you know the molecular signature, if it's PFA or PFB, and I put in the references. Okay, man, that was intense, all right? We still have 9 minutes left. I'm going to stop, hopefully a minute or two early to allow everyone to get their 7 o'clock conferences. Okay, that was a professorial challenge. I think we need to do a Padawan challenge. That was so intense, and I think we'll probably end. We'll end with the Padawan challenge. For those of you who don't know, a Padawan is a learner or apprentice. Here it's from the dictionary.com. The term can refer specifically to a Jedi apprentice in the Star Wars universe, which I think most of you, that's what you're most familiar with, and I would be remiss if we're talking about Padawans, not to mention Ahsoka Tano. Ahsoka Tano is probably the most famous Jedi Padawan currently right now because the Mandalorian and and not the Mandalorian and also Clone Wars, this sort of thing. Now you can see that is basically this is the DK Reader's book, which introduced Ahsoka Tano to the world, and you can see this was beginning to read alone level 2. And I remember back when I was beginning to read alone in 2009, this was my favorite book. Okay. It can also mean, I'm using in this sense, a trainee, a beginner, or an inexperienced person. All right, ready? Padawan challenge. Everyone's a winner. Ready? Here we go. What is your diagnosis? Diagnosis? Anyone want to unmute? Give me a diagnosis.
Colloid cyst.
Yes, very good. Very good, Padawan. Very good. Colloid cyst. Okay. I think that is a great place to stop. I did have another case, but it's 6:52. I think everyone needs to get to their 7 o'clocks, as do I. This is a perfect time, I think, to end the conference. We will have 2 conferences in January. One coming up, it's either the 4th or the 5th. It's at 3 p.m., and then we're going to have another 6 a.m. later. The announcements will be coming. There is no conference this Friday. We're going to go into January, and January is going to be fantastic. I promise you the next conference is going to have a lot of new information, topics we're going to cover. Thanks to everyone for attending, and I will stop it there. I hope everyone has a great weekend. I hope everyone has a great holiday season. I hope you are able to take a break and come back refreshed and ready to go in 2021 for the IDMCC. All right, and I will stop there. Thank you. Have a great day.
Thank you.
Thank you.
My pleasure.
Thank you. That was great. Thanks.
Thank you, Dr. Fuller.
Oh, thank you. Thank you for